Good morning, Professor Cribier. Can you hear us from Buenos Aires?
Yes, we can see you. You look beautiful, and you have a beautiful cat lab, and you have a beautiful hat, and so we are very pleased and thankful, for you to be with us at this workshop. So, my friend, thank you again, and maybe can you introduce your team and the patient case, if you don't mind, Dr. Ortiz?
Yes, perfect. Thank you so much. For us, it's a real honor to participate. Thank you so much, Professor Cribier, Hélène, for having us there for this terrific meeting. On my right side is Dr. Carlos Fava, Dr. Joaquin, who is our fellow from Ecuador, Christian, a technician, Danielle, Alex as a nurses. Juan is going to load the valve, and the anesthesiologist is Dr. Jaime, and our echocardiographer is there.
Yes.
Yeah, so she's ready to describe the echo soon. So let me present the case, la primera diapositiva, the first slide. Thank you so much. Next. So he is 89 years old male. Actually, this is a mistake, sorry. He presented with a syncope. He has history of hypertension and severe coronary disease presented last year. He was evaluated by our clinician and considered him as not futile, but he underwent a significant evaluation because he has a little neurocognitive dysfunction. So at the end, they consider that the procedure is not going to be futile. Next. So he has previous conduction disturbances. He has a PQ of 280 seconds with the left anterior fascicular block. The blood test is quite normal, some anemia with 37. His body mass index is 33. At the echo Doppler in another center, he presented with, or it showed preserved left ventricular ejection fraction 57 with some significant hypertrophic. An aortic valve sclerosis with estimated area of 1.2, so a moderate aortic stenosis with gradient of 30 and 17 with a Vmax of 3.5, but with severe aortic regurgitation. So he has severe coronary stenosis. I will show you the coronary artery disease. Next slide. So this is the ACG that I have already described. Next. Proxima. So and here we have the angio done last year. As you see, a very severe coronary artery disease with significant calcification, very tight stenosis on the LAD, on the circ, and a very big first diagonal branch. Next. Proxima. So you see in the AP view this very tight stenosis with almost a completely occluded LAD. Next. So at that time, the patient underwent PCI next, and it was treated. And now this year we have this severe short stenosis on the LAD, which was treated before this procedure 2 months ago. Next. Next. So this is the orthography during this angio. As you can see, a significant aortic regurgitation with some aortic root dilatation. Next. So we did a CT scan. As you can observe, there is some calcium, but not too much. This is a tricuspid aortic valve. Next. And we did several measurements of the annulus with different operators to correct some mistakes. So we have already found this diameter of 23 at 29 with the mean diameter of 23 with a perimeter of 82 and area of 517. Next. This was done in the core lab with an area of 507 with the diameter is quite similar, 21 and 29. There's some movements on the CT which is not perfect. The next. This is the LVOT 21 by 30 and the area of 510. You can see the valve there, big annulus, big sinus, 38 and 37. Next. This is the ascending aorta, 37 with a sinusoidal junction of 32. This is the valve calcification that I showed you in the previous picture. Next. This is coronary height, 12 for the left, 18 for the right. Next. And this is another significant finding. This is a very severe aortic angulation with 65 degrees. Next. And this is the implanter's view that we use for almost all the valve in the cuffs overlap view on the right caudal angulation, 3 the right, 29 for, 29 yes, for caudal angulation that we have chosen based on the CT scan. Next. And this is vascular access, which is acceptable with some calcification on the common iliacs and also in the femorals, in the common femorals. Next. Anyway, we decided to proceed by right femoral percutaneous access. Next. So at the NSMA 89, severe symptomatic aortic valve disease with coronary artery disease. The STS for mortality is 4, the morbid mortality is 10. But the heart team suggestion was to correct this short stenosis and to proceed with the TAVI procedure. Next. For this case, we have decided to use this balloon expandable valve based on the not too much calcification, a severe aortic angulation with a predominant aortic regurgitation. We are going to use the bivalve that you probably have already described. I don't want to spend too much time on that. Next. Next, click. According to the area. Yeah. Yes.
Just because I just wanted you to show the chart here to understand which size you selected. Yeah. Thank you very much. Thank you.
Yeah. So according to this, probably on the next, I will show you. You see the diameter is for the which valve we have selected.
27.
20.
27.
27.5, Professor Cribier, is according this. But I will show you in the next slide.
That's great. That's great. Thank you very much. Thank you.
The next one, please. Here, click. So according to the sizing chart for bivalve, using the 27, we are going to have probably a 14% oversizing. So hopefully you agree on that, because this is not so calcified valve with a severe angulation, with a predominant aortic regurgitation. Do you agree on that?
Yes, absolutely. You're right.
Okay. I think it's the last one. Next. Proxima. Okay. So we are planned to do, okay, stop the slides. So let me tell you what we have already done here. We have a bilateral femoral access. Based on these previous conduction disturbances, we put a pacemaker on the right ventricle that is going to stay there at least for 24 hours. If this conduction disturbances does not worsening. We have here the Python sheath that we have to pre-dilate. This is a 14 expandable sheath. We have the dilator here that is gonna change the size to the 18 sheath. We have done the echo. On the echo, if you want to see, probably you can describe a little bit.
Yes. First of all, the patient has left ventricular concentric hypertrophy with a normal left ventricular function estimated in 60%. And the patient has a mild calcification in the aortic valve with severe aortic regurgitation. The peak velocity was 2.6 with 18 of mean gradient and valve area estimated in 1.4, so it's a moderate aortic valve stenosis, and predominant is the aortic regurgitation, as you can see here. Okay. And also important to mention that the patient has a mild pericardial effusion previous the procedure.
Well, this is very important that we always check from the beginning before to put wires inside all the ventricles if we have a previous pericardial effusion, so that we have to control after the procedure if it's stable or something is changing. So let me show you the answer. Yeah.
May I ask you a question?
Yeah.
Concerning the sheath, the Python sheath, It's a 14 French, and you said that you were using a dilator. So what size is the dilator? Is it a 16 French, 18 French, or
It's gonna, yes, it's a dilator for 18 French sheath. So the
18?
sheath is gonna expand up
No,
to
it's just
18.
to understand, you start with a 14 French sheath, but you over dilate with
Yes,
the 18 dilator.
yes,
It's
exactly.
because of the size of the valve, because of the sizing of the valve, which is relatively too big for the sheath.
Yes, yes,
It's
absolutely.
interesting. Yeah, okay.
Let me show you the ancho because we only have, I think, 15 minutes more. And this is the ancho in the cast overlap view. We did, mostrame la primera. So we did echo, la primera inyección. Echo guided puncture, but we try to find the spot of calcium and to be above the calcium. So I did the ancho. Next, la próxima. So I put the needle to be sure about the height of the puncture, and then I use the echo for guiding. I cross the valve, and now I have the pigtail there. I will introduce the dedicated wire. As you can observe, there is a significant angulation there. If I think you are going to agree, we are not going to pre-dilate because we don't have too much calcium.
No, yeah.
So we are going to
there is the aortic regurgitation, which is significant here.
no tires de la guía. So I'm going to dilate the sheath. If you show here, I move a little bit. So now Dr. Fao is going to hold the sheath. It's fixed to the skin with a suture, but it's not so strong. The idea also is we usually use pacing at 180, but this, vamos con la válvula. For this aortic, almost, I wouldn't say pure, but predominant aortic regurgitation, I will try to go to pacing a little bit higher at 200 people.
200, yes.
We have prepared 2 cases for today, but we decided to live this one because I think it's a little bit more challenging than the second one.
Yes, yes.
Sí, miramos la punta del sheet, asegurarnos. So we try to... Soltalo un cachito, soltalo. So here I can see the wire, stop, and I can see the valve before leaving the sheath to be sure that it hasn't moved. Soltámelo un poquito. So it's perfect on the balloon. You agree on that? Solta. Okay. So it's a deflectable sheet. So we orient it. Mostrame arriba en oblicuo izquierda. And now we have a significant aortic angulation. So I am going to deflect the sheet a little bit here to facilitate this curve. As you can see, it was easy. Vamos a la derecha, vuelta. Okay. I'm gonna deflect more. The wire is in position. Let me check the pigtail. We have to repositioning. It's extremely important, the position of the pigtail test. No, give me the unplugged wire. I'm going to reposition the pigtail. I will pull the wire a little bit because I don't like the configuration of the distal part. In this patient, I have a dilemma: conduction disturbances and the safety of the valve implantation. Probably I'm gonna go a little bit deeper than usual. I don't know if you agree with me, Professor Cribier.
Yes, yeah, of course. Yeah.
So the idea is to check the position. Vamos a hacer un test ahí. I think the position is okay there. Probably it's a little bit deeper than usual, but again, if you agree, I'm gonna go there.
Would you please tell us how will you check the position of the valve just before
there?
delivery?
So the second dark line should be at the level of the annulus, but here probably I am a little bit deeper. But again, I don't want to to take too much risk in this patient. So,
Okay.
desk. So, okay. So, Carlos, 200. Carlos is gonna wait. So we are going to inject and vamos. So I am pushing a little bit. 5. Deflating.
Cortalo.
Okay, stop pacing.
Stop pacing.
Okay, déjalo a 80.
80.
Okay. Okay. So our frequency, it's a little bit lower now because I was hearing Helene's description of a case of pop-up before, so I scared a little bit. So I'm gonna
Looks like an excellent position.
rectify the sheath. Now I'm gonna use the unplugged wire to retrieve the pigtail.
Okay.
From there. So we are going to do an injection. I think we still have 10 minutes. Is that okay?
Yes, yes, you can take your time. Just for us to know, you always leave the pigtail in the cusp at the time of valve delivery. You don't fear any kind of jailing the pigtail against the wall of the aorta?
Pone
Or
20. Thank you for the question. I usually leave it except for patients with a small sinotubular junction and significant calcification above the right above the non-coronary cusp. Yeah.
okay.
In these cases,
This
I
is
try
what I
to.
was
Yeah.
absolutely.
I think this is the target that I try to get. The valve is probably 1 millimeter deeper than usually, but I like the position because, you know, there were not too much calcium. Pone de frente, let me show you the echo and we can decide what to do.
Well, I think it's a very excellent result.
I think, yeah, I think yes. But anyway, we can check by echo that everything is okay. The wire is still in place. Maybe while she is doing the echo, I can pull the delivery system out and I can introduce the pigtail. Floro, Carlos. Un segundito. Okay. Okay. Give me the pigtail. Patient is completely stable. The HCC, let me check, probably widen the QRS. Yeah, probably with the left bundle branch block complete, but the PQ seems quite similar.
Yes.
I usually bend the wires near the tip to help, if you can show my hand, to introduce, especially for self-expandable, but here also in balloon expandable, I try to do a secondary bend to facilitate the navigation and also to get a better alignment. Probably in this case, a question that I asked myself was about using a stiffer wire, like a Landerquist, but I decided to proceed with the regular one. We used, I think it was the Confida. I don't know if some of you would have used a stiffer wire like Landerquist or something like this.
Never.
Okay.
We never use it. No.
Yes, me only for very few cases, especially for very complicated vascular access, but not.
This is the only indication. Yeah. Absolutely, I agree.
Yeah. The only, in my opinion, the only First indication is when we have abdominal aortic aneurysm. In this case, probably I will always use Landerquist because I had a complication many years ago.
Yes, I totally agree with you. Totally
So we have the hemodynamics, which looks really nice.
Observing the hemodynamic results, which
You
are
see,
absolutely unbelievable.
you can see hemodynamics there.
We are opening a bottle of champagne again.
Please wait for me. Or maybe if you are going to Slovenia with me, like last
Yeah,
year,
sorry.
we will see there and we can share the bottle. Could you describe the echo, please?
Yes, the prosthesis is well positioned with a peak velocity of 1.5, and the gradients are, the mean gradient is 5, and there's a mild leak, but really mild, and there's still the mild pericardial effusion that we described before.
Could you show the
Yes.
leak?
Oh, sorry. This is the mild leak.
Oh, really mild.
Really mild. That is medial and anterior.
So I think we are done, Professor Cribier. I don't know if you... let me do a final answer there, probably with the more CC.
You don't care about the price of a paramedic, which is absolutely nothing, and the case is done and with excellent result, and it's a beautiful case. May I use this opportunity, Dr. Mendiz, to ask you what is your experience with the MyVal, or did you have an experience with the octa-core valve?
We have a good experience with the My valve. Unfortunately, we don't have still the octa-core in Argentina. When it's going to be one? Probably next year, probably at the beginning of next year, but not so far. We need to, or actually they have to do errands for the approval. Regarding our experience with this My valve, we have very good outcomes. We are using not only for aortic stenosis, we have mitral and tricuspid. And last week we also did the pulmonic valve implantation with this My valve in a patient with severe pulmonic aortic regurgitation and previous conduct surgery. So we have treated all the valves with the My valve. The only experience that we have was another poor aortic regurgitation that we have a pop-up. We have to reposition in the valve, and we have to implant the second valve, and the outcome was perfect. If I had to tell you, the learning point of this case is probably what we have used today, pacing a little bit faster, and inflation of also a little bit faster to prevent this pop-up. And
yes, my personal view on the MyVal, I have seen a number of cases. I have never seen any aortic regurgitation or pacemaker. Do you agree on the fact that it's a device which is associated with excellent rate of pacemaker and AR?
Absolutely. Probably this is not going to be the case. Dr. Fava is doing an analysis that I am correcting and rewriting for publication. We have found with self-expandable, but let me tell you the finding, which is important, that or patients with previous conduction disturbances like this patient, the incidence of pacemaker with self-expandable is about 25 or even higher, but without, it's only 2.6 or something like this. There's a huge difference. So this is another reason for using in this patient a balloon expandable valve. But anyway, he is a patient with 280, remember, PQ. So I don't know. And I cannot go as high as I would like in another cases because I don't have enough calcium to be safe.
Yeah, fantastic. Fantastic. Dr. Mendiz, I want to thank you again and your team for having spent time with us. You demonstrated again a wonderful case, with optimal results. Are you planning to close the femoral artery with ProGlides, or How would you close the femoral artery in your center?
We have one progly. We are going to close this progly over a 6 French sheath, and then we will introduce an 8 French angioceal. Before that, I'm going to put a mammary catheter just to have contralateral control to be sure that we don't have some bleeding.
Mamario.
Mamario?
Mamario.
And the other probably additional point here is I have a wire here. I'm going to pull the sheath,
Estos son.
but before I'm going to introduce the dilator to prevent artery damage, because you know it's expandable sheath. It has some wings that can damage the entrance, but nothing so special. Mostrame la panza.
Abajo.
Okay, so I will leave the mammary catheter there just in case I can cross over and so on. Dr. Fava is gonna hold the groin. I'm gonna cut the suture. Hopefully I haven't cut the progly. Mostrame un poquito más abajo, dame esto primero. It's okay, no, tráelo para tu lado, para allá. The other issue here is about the heparin reversion. If the patient doesn't have stent, we can revert. But in this patient with the previous PCI, probably I would not use it. You see, that's what I was talking about. When you retrieve the sheath, it's better to have.
Forward. Yeah. You need to put the dilator in.
Yeah. And now I can introduce T6 because I have a feeling of how the thing is going on. If we have something important, we can decide to go contralateral or to do something else. But as you can see, we have some oozing. Probably we have some hematoma that was when we were waiting. So I'm gonna let me check here, and we can show to them how the situation is. Before introducing the progly. Muéstrame acá, Pip. Saca la mano, Carlos. Sí. Un poquito más abajo. There. So with one progly, so the situation is absolutely under control. So anyway, he is a very old patient. He is gonna move. I'm gonna introduce the angioceal anyway. Do you agree?
Yeah. Sure.
Especially because we are not reverting the heparinization. He received 10,000, but 1 hour and 15 minutes ago. Vamos.
I forgot to ask you the question, is the patient sedated or did you give a general anesthesia?
He is under conscious sedation. He is receiving dexmedetomidine. Yes.
Okay, I just want to make sure.
Yeah. We have done only few cases under local anesthesia, but our population here, they are almost very old patients, very sick. It's not that easy to keep them calm and comfortable during the procedure. So that's why we rather like to use this sedation, so we have help in case of something is going wrong. So,
do you have an anesthesiologist in the room with you?
Only for these procedures, not generally based or daily based cases. But here we have Dr. Jaime. He is originally from Colombia, so as you can see, we have a very international team. Yes. The only day that we disagree each other is when we have soccer games against the others. Okay, let me test. So everything is perfect. My target was to be above this calcium. So I think we are done. We are fixed now the pacemaker, and we put another angioseel here to close this femoral access. It says 6 French? No, 6. So we have to wait a minute for that. What else we can bring from Argentina to you? Something important is, you know, we attend many meetings where we discuss about which valve to select. In Argentina, sometimes it's not that easy. It's not that easy because health insurance companies, in most of the situation, push you or obligate you to use one or the other valve. For example, for the retired people, the health insurance always send to us a self-expandable valve. We have to convince them about the need of a balloon expandable, so they accept in this situation, for example, when we have such a severe angulation, but it's not that easy. So it's something that probably in Argentina, hopefully change soon, but sometime, or excuse me, nowadays we have to deal with that.
Okay.
But fortunately, because when you contact me, I was doubtful, we can find not one, but 2 cases. I will do the second alone, but the other case is a regular case, is not interesting. I think this one it was much interesting.
That you could manage to make a case. You know, it's absolutely amazing to see working.
So everything is finished. Okay, I think we are done. We can say thank you to you for having us. Please, Rich. I would like to thank Rich, who is control all the live transmission from New York, from Broad Media. Thank you, these guys, for helping us. We are close here the skin with one suture, one stitch, and that's it. So thank you so much. Hopefully see you soon.
Amazing 30 minutes case from skin to skin, you know, and with a new valve in place. And well, congratulations. We really appreciate to observe you work in our cat lab. Goodbye, Dr. Ortiz. Thank you.
Thank you. Bye bye.